Alrighty, where were we? So this is section 2 of the cardiovascular review for the AANP exam. We stopped at vascular problems. So we're going to talk about the difference between PAD and PVDs. The easiest way to remember PAD, you know how it has P and A in it? Well, P stands for pain. The patient will be complaining of pain. And A stands for absence of pulses. So when the patient has pain and absence of pulses, you're thinking PAD, okay? And you diagnose it with ABI, and if it's less than 0.9, then it's diagnostic of PAD, okay? Easy, straightforward. So the first line of treatment is lifestyle changes. You gotta tell them to stop smoking and start walking. And if that doesn't work, then you move on to Plavix. Now with PVD is a volume problem. V, because it has V in it, think about volume, okay? So it's an increase in fluid in the lower extremities. There's no pain and no absence of pulses, you know? It's just discomfort because of all that volume overload. That's your PVD. Chronic venous insufficiency, CVI, is lower extremity edema and discoloration, and it's warm to touch. What happened is it's impaired venous return. So encourage compression stocking if they are not contraindicated, of course. Homan sign is lower leg pain when the patient does dorsiflexion, and it's a sign of DVT. Okay, remember Homan is a sign of DVT. Okay, it's when the patient has pain when they dorsiflex their leg, their foot. Moving on to Raynaud phenomenon. You remember this a little bit from nursing school. A little bit of story there, or mnemonic or whatever, is it is a vasospasm of fingers and toes, mostly happens in women. So I want you to think about Mrs. Raynaud, okay? She's Mrs. because it mostly happened in women. And she's a female. She comes to the clinic. She's complaining of color changes in her fingers in symmetrical pattern with white, blue, and red color discoloration. So it's pretty much the American flag. So think about Mrs. Raynaud carrying the American flag, showing up to your clinic and showing you, oh my God, look at my fingers and toes. They keep changing in colors like the American flag. She also is having numbness and tingling and feeling cold in the tip of her toes and fingers. So you treat it with calcium channel blockers and tell her to stop smoking and tell her to avoid like Sudafed or anything that's vasoconstricting. The carotid bruit, it's mostly caused by carotid artery stenosis. You remember that a little bit from nursing school as well. Thrombophlebitis, the superficial thrombophlebitis, this happened because of indurated veins. You just give some NSAID and you elevate, okay? Easy stuff. Now moving along to dyslipidemia. Now I need you to remember these levels, normal lipid levels. So TC is your total cholesterol. The normal is less than 200. Triglyceride, TG, the normal is less than 150. LDL, normal is less than 100. And HDL, that's your good lipid, the normal is over 40. Remember these because this will help you answer any questions that are related to treatment of high cholesterol, high lipids. So the rules are you treat LDL first, usually, except when the triglyceride is over 500. If the triglyceride is over 500, you have to stop treating the LDL and focus on your triglyceride, okay? If the triglyceride is less than 500, you can just treat your LDLs with your statins and call it a day, okay? Now, when your triglyceride is over 500, then you treat it with niacin first, and then fenofibrate, and then gemfibrozole. So these are your lines of treatments for TG that's over 500. We treat TG if it's over 500 because high TG puts the patient at high risk of pancreatitis. So you cannot have patients walking around with TG over 500. That's crazy. That's a lot. Okay. Now, that's another scenario right there. If the triglyceride is 280 and the LDL is okay and the HDL is okay, then all you do is lifestyle modification. Okay. Remember, you don't treat TG if it's less than 500. So they will trick you on the test. They will try to say, oh, look, the triglyceride is high. No, if it's over 500, then you treat it, okay? If it's still high but not over 500, you focus on your LDLs and you treat your LDLs with statins. I hope that makes sense. Moving along to the next section here, statins are used to treat high LDLs. If the patient is already on niacin and their triglycerides still high, that's when you add your Tricor, and you can even try insulin infusion. So after you've tried your niacin and it didn't work, then this is the other options that you have as well. With statins and niacin, you get high risk of rhabdomyolysis. Okay, remember that from nursing school, and liver disease. So this is when you need to watch your patient closely and make sure they're not showing signs of that. Now, next here we have hyperlipidemia treatment protocol. So this section is a little bit confusing. It will start, if you read any review book, it'll start talking about when do you start your high intensity statin, when do you start your moderate intensity statin, when do you start your low intensity statin, and it just goes into so much detail. So I try to condense it in here into this little section. So before you know your treatment protocol, you need to know what is an ASCVD risk. So remember these: MI, CAD, angina, and stroke, TIA, and PAD. Okay? For patients that are less than 75, with any one of these ASCVD risk factors, you start them on high intensity statins. For patients less than 75 years old with 7.5% of ASCVD risk, you start them on high-intensity statins. For all patients, no matter how old they are, with LDL over 190, you start them on high-intensity statins. Okay? If you know these three scenarios, then most likely you're going to answer this question correctly. And an easy way to remember your high-intensity statins, the Lipitor is 40 and Crestor is 20. This is the high intensity, okay? So if it pops in the answer choices, you know these are your high-intensity statins. Now I have a mnemonic. Mnemonic is coming up, you guys. Hopefully this is a good mnemonic. I like it. I used it a lot, even in nursing school. Fan mag. So it's like you're a fan of a magazine or something. I don't know. Fan mag. Mag is like a magazine. Think about it. So fan mags are what interacts with statins. So F is for fibrate, A is for amiodarone, N is for niacin, M is for macrolides, and A is for antifungals, and G is for your beloved grapefruit. It'll pop a lot. Grapefruit will pop a lot. Fancy name for statins is this beautiful, lovely name over here that I'm not going to even attempt to say. Do not mix statins with niacin. And then here there's some signs of rhabdomyolysis. And you should know that from nursing school already. Moving along to metabolic syndrome. So you need to know your BMIs, the 5 classifications of BMI. And then I have here my new mnemonic. That's also I'm introducing high FOD. High FOD. That's my mnemonic for diagnostics for metabolic syndrome. So high FOD, H stands for hypertension, F stands for fasting blood glucose, and O stands for obesity, and D stands for dyslipidemia. With TG is high and HDL less than 40 in men and less than 50 in women. So high FOD, the I doesn't mean anything. It's just there because I want to make it high, just to make it into a mnemonic. Okay, don't worry about the I. It's nothing. So these are your criteria for diagnosing your patient with metabolic syndrome, and you need 3 of these. Okay, remember high FOD, that's 4. So you need 3 of them in order to diagnose your patient with metabolic syndrome. Here there's a little section about AAA, which is abdominal aortic aneurysm. That's your typical AAA patient is a male who comes to your clinic, who have smoked in the past, and he's complaining of abdominal and back pain, and he has a different blood pressure from left to right. He has abdominal bruit, he has pulsation, so that's when you say, "Oops, this could be AAA. It's a medical emergency." You diagnose it with an ultrasound. And then moving along to abnormal heart rhythm, you should know this if you work at the hospital as a nurse or nursing school. It's just a little quick review. Remember your AFib. It's the rhythm that has no P wave and it's irregular. That's your AFib. A newly onset of AFib and patient been taking digoxin for 10 years. What do? So the patient has been on digoxin for 10 years, but now they're starting to have AFib out of nowhere. What do you do? So first you order digoxin level, see how we're doing. Then you order your electrolytes, you order your TSH. Remember, you're trying to rule out thyroid problem. And then you stop the medications that the patient might be taking, like Sudafed or theophylline or all these meds. SVT, that's when the heart rate is 150 to 250. And that's when you get your lovely Wolff-Parkinson-White syndrome. Never heard this word in real life, just saying. It's a textbook thing. And you treat SVT with digoxin. Here, there's a little bit about digoxin. It's given for SVT. It's a single dose, and it lasts for two to 5 days. It has a very long half-life. So don't give it to elderly. It's bad for our elderly patients, okay? And then here we have a little bit of heart blocks. The first degree is just long PR intervals, okay? Remember that. The second degree, remember your Mobitz 1 and Mobitz 2 from nursing school? So Mobitz 1 is progressive elongation of PR. Long, longer drop. Long, longer drop. That's Mobitz 1. Mobitz 2 is the same length, but QRS all of a sudden decide not to show up, okay? Your isolated systolic blood pressure in the elderly means they have a high difference between systolic and diastolic. And here we have a little bit of notes about angina. Stable angina, it occurs with activity. Okay, that's stable. If it's unstable angina, it will occur at rest, would come out of nowhere. It's unstable. And that's when you get your consult for cardiology. And the best way to diagnose the type of angina is the patient history. You got to ask these questions. When do you get this angina? MIs. So if angina is not relieved at rest, and it lasts more than 20 minutes, then now it's not an angina anymore, it's an MI. That's when you call 911 and take your patient to the emergency department. MI can be atypical signs such as nausea, vomiting, fatigue, syncope, back pain. If the patient is complaining of chest pain radiating to their neck or left shoulder, always do an EKG to rule out MI, any kind of chest pain, and that's a given, you know. So what happened with EKG? The EKG, when a patient has an MI, will show ST elevation on V2, V3, V4. And then you get your infamous tombstone QRS on an EKG as well. You give beta blocker to patient after they have MI, and the patient describe angina as someone is squeezing my chest. The MI, the patient describe it as an elephant sitting on my chest, okay? And then angina is SD depression most of the time, and MI is SD elevation most of the time. So just remember all that. IE, your infective endocarditis, that's when the patient has fever, chills, murmur, Osler nodes, Osler nodes, it's not even nodules, it's nodes, Janeway lesions, and nail hemorrhage. So the little mnemonic that I use to remember my IE symptoms is Osler. There's a guy named Osler. He's showing Jane his fingers and nails, and Roth eyes are hemorrhaging because of it. Okay, I don't know, okay? Because first you have to remember Osler nodes. They're purple petechiae on the fingers. And then you have to remember Janeway lesion. So Jane, that's your Jane. She got red spots on the fingers. And then there is some nail hemorrhage going on. And then there's what's called Roth spots on the eyes. So good luck remembering all these names. I don't know. I start pretending they were people. Osler, Mr. Osler, Miss Jane, and Miss Roth. Good luck. You treat them, you refer them to cardiology, and you hospitalize them for IV antibiotics and blood cultures within 24 hours. So the antibiotic for IE is not recommended before mitral valve prolapse. Not recommended, okay? They will ask this question. They love to ask this question. I don't know why. Or for any procedures that's invasive, such as GI invasive procedures. However, antibiotic prophylactic for endocarditis is recommended if and only if there's an existing infection. Like, let's say the patient is going for cystoscopy and they already have an existing UTI. That's when you give them prophylactic antibiotics. And here we have the last little section that I have is MVP. It's your mitral valve prolapse. The way to describe that, it will be described on the test as a mid-systolic click. Okay, it's heard on the mitral side, hence the name, right, mitral, and you treat it with beta blockers. It can have a lot of complications, so treat that. And last but not least is your pericarditis. It might show up and they will say, oh, the patient's having pericardial rub. What could it be? After their upper respiratory infection. Once they give you these two clues, you know they're talking about pericarditis, okay? So yeah, this is my cardiovascular section. Good luck and have fun studying.